Very much good.
Actually, this year
So good evening, everybody. On behalf of the Indian Society of Oncology and me personally as the president of the ISO for the next 2 years, it's my distinct pleasure and privilege to welcome you to this webinar. And this time we've kept like an interesting topic, nitty-gritty of next generation sequencing with special reference to non-small cell lung cancer. And we've stitched together a few country leading experts who will give us insights into this interesting topic. So, all of us in our patients of solid tumors and many times liquid tumors also, we ask for an NGS panel. And some of us, or I would, venture to say that the majority of us don't understand this NGS panel which we've ordered. But we do it because the patient wants it, and because if we don't do it, then the next oncologist will do it. So, like, we are trying to make this attempt, and we will continue this series in the future also, so that we understand the nitty-gritty of the NGS which we order. And this time we are going to focus on a non-small cell lung cancer in which so with these few words, with these a little bit of preamble and introduction for the today's webinar. This is the 15th, by the way, in the ISO webinar series. I hand over to Dr. Sumant to take the program forward. And I'm absolutely sure that you will enjoy the program and you will learn from the program. So over to you, Sumant. Thank you.
Thank you, sir. Thank you for giving us the guidance to host this seminar, this particular workshop on nitty-gritties and NSCLC. So the first moderator for the day, and I'll say the only moderator for the day, will be Dr. Akhil Kapoor. He'll be leading us with a very esteemed panel of doctors who will be discussing today. So Dr. Akhil, over to you. Dr. Akhil is the professor at Tata Memorial Center in the Department of Medical Oncology at Varanasi and a very good friend and a dear colleague.
Thank you. Thank you, Dr. Sumant. Thank you to Dr. Hemant, sir. So basically, as we know, as sir was also trying to highlight, it is very important to understand the intricacies of NGS because now it is being rampantly used, and thankfully the cost has come down significantly. Now we'll see how to integrate it into the routine practice and how we can understand the basic finer points which are sometimes missed in busy oncology practice. So this is what we are trying to find. We are trying to find mutations which are actionable and useful. And this is one of the study in advanced lung cancer, a single center experience of 1200 plus patients, which has been recently published last year in clinical lung cancer. And what we see, the NGS testing has significantly increased in Tata Memorial Center group of hospitals. It was just 7.5% in 2019, and it has increased to more than 50% patients. And I am sure it is in 2026, which is 3 years from 2023, it has crossed to a more than 70 to 80% at least of all lung cancer patients. So I will first take a comment from Savita ma'am. For her comment, if she's available for comment. How, Savita ma'am, do you see the increasing use of NGS even in resectable settings in your practice, ma'am? Just comment and how you have seen the changes during your entire practice in last decade.
So definitely there is a widespread use of NGS in resectable stage also. Initially, before say 2017-18, we would think that it was only for stage 4 for the metastatic setting. But more now, even when a patient has any tumor more than 4 centimeters, it's clearly resectable. Just the size more than 4 centimeters or any hilar node, which is N1, we would always want to get at least a PD-L1, EGFR and ALK done, and consider the patient for neoadjuvant if the patient is willing, fit, and we discuss it in the MDD. So there is a huge change, and this change is not only in the acceptance of surgeons, that the resectable patients should also undergo MDT and should undergo this multimodality pathway, because usually surgeons want to hang on to their patients. The resectability rate of lung cancer is very low in our country. So when you get a resectable patient, you don't want him to go anywhere. But this mindset has definitely changed, more so in the last 3 to 4 years. And also now the patients are very accepting. So when you say NGS or you say molecular testing, almost 50 to 60% of the patients understand what you're saying and they are accepting of it. So that is a big change that we have seen. It's not like before when patients used to say, just take it out. They used to tell us that just take it out. Now they are willing to understand, willing to have a dialogue and discuss this.
Yeah, so the patient education is a very important factor. Thankfully, awareness, and as Savita ma'am highlighted, the awareness of the patients is significantly improved. And there is also some significant role of various foundations and NGOs which are surrounding us. Actually, that has helped us. I will take just one name. Lung Connect India Foundation has actually helped us in our OPDs, and it is doing a fabulous job. Now, we have various mechanisms by which we can get NGS even for non-affording patients. One of them includes option of a clinical trial, and second is through Lung India Alliance. I think that these two have significantly helped us. And at our center, we have 7 clinical trials in the first-line lung cancer, advanced lung cancer actually. And NGS is a part of pre-screening in all the trials. So the patients get testing then through or some or the other mechanism that we have ensured. Omshi ma'am, coming to you. So,
Akhil, can I interrupt?
Yes,
Dr.
sir.
Lalit Mohan Sharma here.
Yes, sir. Yes, sir. Please go ahead.
In fact, we will love to know from you that which trials, mutation-driven trials are currently on. You can put it in the chat box so that it becomes easy for us to take help for patients who are not able to go for mutation-driven
Sure,
treatment.
sir. Sure,
Thank
sir. I
you.
will
Please
provide
go
a
ahead.
list definitely, sir, so that it
Thank you so
can.
much. Thank you.
It is both mutation-driven trials are available at the same time. Multiple immunotherapy trials are available. Now we have got funding for a microbiome research, and it was a non-interventional project. Now we are proceeding towards microbiome interventional project. So hopefully this is another area where NGS for tumor mutation, and now we will move towards that. Is microbiome testing is also NGS driven. I think Omshi ma'am can put some light on that, because presently we are focused on NGS for tumor, but now I think the value of NGS is evolving beyond that, and we are all understanding it gradually. So just a few words from Omshi ma'am regarding the widespread use of NGS, not only for mutation testing, but also for microbiome testing, which is coming up, ma'am. Ma'am, you are muted.
Yeah, hi. Thank you, Akhil. And I must congratulate you for the number of trials that you have included and which has been made possible for the patients to be enrolled in these studies. So we know even if it is not in TMH in Varanasi, at least those patients are getting enrolled in the trials. Coming to testing, yes, I mean, when we started also, we started with the smaller limited panels, which has now expanded to comprehensive genomic panels. And even the clinicians also don't mind, and even the patients are also very much up for it. And besides that, it is not only about the gene or the targets or specific to tumor. We have expanded the scope to we now want to look into the tumor microenvironment, the tumor immune involvement, whether it is a hot tumor, cold tumor, and not only that, it is the entire microbiome. So microbiome would also affect the entire heterogeneity that we would see, and the way that specific tumor would respond to the treatment. So it has become like a holistic approach, or rather I would say it's not only the genome. We are also in an era where we are talking about the methylation. So probably genome would have been something like a tip of the iceberg. Rest of the entire information is still hidden behind. We are not seeing way beyond what is happening, because at times we might see the same mutation present in two tumors, but the way the patient would respond to the treatment would be totally different. So that would makes us believe that, this is definitely beyond these markers. Of course, we have hit the target. They might respond, but something else is also playing at the backdrop. It could be the microbiome, it could be the immune environment, whether it is immune rich or it is immune depleted, or whether there is any anaplerotic reactions which are going on, or it is a microbiome, what kind of, or even the ethnicity, the food habits, the multiple things would play a role in it. So it is more or less like now a overall holistic view that we are looking at.
Yes, ma'am. So I completely agree. So we are evolving very fastly beyond, and you have clearly highlighted, ma'am, that same patient, similar mutations, they respond differently. And this is not because of the tumor factor. This is likely because of the host factors, and microbiome is one of the component, at least we are now understanding. Even every day we keep on reading in newspapers also that microbiome has been found to have some implication in dementia, in other diseases. So it is microbiome is not hampering, leading only to cancer outcomes, but it has impact on multiple other factors, multiple other diseases, multiple things, so which we do not understand till now fully. So I think this is one of the very fast evolving field, and we will keep on getting some more literature and research. Yes, Lalit sir, you wanted to make a comment.
I wanted to ask Dr. Omshri that like the microbiome NGS, we are doing from blood or tumor or from some other source.
Sir, it depends like what exactly you're looking for. Sometimes it could be the gut microbiome. So that is like you will take the stool sample, or if you want to do it from the tumor samples also, you need to have fresh tumor tissue. So of course, these things are not into routine practice, but now it is more in the explorative phase.
Thank
So
you. Thank you so much.
yes, sir. Presently, gut microbiome is under the strongest, has the maximum data. Yes, as ma'am was trying to highlight, tumor microbiome, this is slightly difficult to study because fresh tissue is needed and sample availability becomes an issue. Also, local microbiomes, for example, if BAL sample is done, and that microbiome is taken. So all these are under study, but gut microbiome being the most accessible, maximum data is on that. And there is some data in RCC which has already evolved, that microbiome augmentation in RCC treatment that will increase the response rates to immunotherapy plus TKI combination by at least 6 to 7 times. So this is what we are looking at. Same drug, just microbiome supplementation, it can lead to completely different response rates, from just 20% to towards 70 to 80% response rates. This is a dream of all the medical oncologists, all the oncologists, in fact, that we want to increase the response rates somehow by using some mechanism. And thankfully, this will be not so costly, because we know that these drugs are costly. Thankfully, we have done so many other studies at TMH and multiple other centers that we are trying to optimize the doses and make the drug available to our patients. So coming to next step, coming beyond microbiome, because microbiome itself will take a lot of time to understand. Let's move towards NGS and understanding. So what we keep on seeing is that the mutation rate across NSCLC is different, and we are seeing quite a good number of ERBB2 mutations. Apart from EGFR rate was estimated to close to 26%. Now, with the incorporation of NGS, we are seeing close to 30 to 40% mutation rate at least. And our center is seeing a mutation rate of 42% to be precise. So definitely the EGFR mutation and all other mutations, we are able to pick up much better. Dr. Sunil sir, I will request your comments. Any change in the mutational profile which we are seeing after incorporation, widespread use of NGS in your practice for both advanced and locally advanced NSCLC, sir? Then I will come to small cell as well, because you have some experience and you have some data for that as well. Yes, sir. You can go ahead. You can unmute and go ahead. You are muted, sir. Please unmute yourself.
I'm audible now? Yeah.
Yes, sir. Yes, sir. Please go ahead.
Yeah. So with the increased use of NSCLC, we have found that there is a potential application even in the uncommon mutations, which are now coming up, as we have already alluded that even a HER2 mutation, HERB2 mutation, and even this EGFR mutation, we have also found an increase in the incidence and detection of that, and even the uncommon mutations EGFR, which are actionable. And besides that, the other these fusions like MET exon skipping mutations, but even in the second line, when also when the patient progresses, we again do a comprehensive a gene panel. We get to see like some actionable targets like MET amplifications. So that actually has helped increase the significantly the targets or the avenues for the therapeutic approach.
Yes, sir. And in a small cell, how do you see in important upcoming roles? Because last year WCLC was focusing more on small cell than non-small cell, because the developments in small cell have significantly increased suddenly in last year.
Yeah, because recently even the molecular phenotype of some classification has been there, and I had a project with Dr. Ullas, and I also presented that in the last WCLC. So there are four different types of these molecular subtypes, like one is a neuro D1, and then there is and then we found that there was a specific subtype that was Pau2F3 positive tumor. So we had that around 8 to 9% in our study that we presented there in WCLC, and with the recent literature, they are showing that these are the ones who have they can have a good response to immune checkpoint inhibitors.
Yes. So definitely, small cell is also now being recognized to have a different subgroups which will respond differently, and now increasing use of NGS, but presently a limited therapeutic application directly in terms of changing the treatment. But yes, definitely it has some prognostic information which we understand till now. One comment I will request from Umshi ma'am about MTAP deletion. So this is another avenue which is rapidly coming up. Besides the mutations rates, which mutations which are being seen on the screen, 50% patients have some or the other mutations. Driver negative is around 30 to 35% at in our country at present. But when MTAP deletion will come, and there is a trial which is starting at our center and TMS Mumbai both, I think the situation will change a lot, because MTAP deletion is another very large group. Around it is expected to be there in 15 to 20% of the patients. So I think that will also change the driver negative patients will become a very small minority in some time. So a comment on that, Omshi ma'am.
I completely agree with you, Akhil, but mostly most of the panels which are used, like the limited hotspot panel or the smaller panels which are there, like the targeted panel, do not contain MTAP gene. So probably it's not that since we have not reported means probably we have not seen those cases. And
Correct.
that's the reason why we have not been reported. Even many of the comprehensive genomic profiling, like the CGP panels, even the 500 gene panel, may not have MTAP at times,
Yeah.
unless and until it is asked for. So its relevance is coming more and more now with probably clinical exome and all in picture and with the data that is available. So once those genes are included in the panel and we start seeing those cases, so even those driverless mutations will certainly have a larger say because of these MTAP loss.
Yeah. So
Dr.
yeah.
Actually, if I may just add to this,
Yes, sir, please.
Actually, we have started MTAP as an immunohistochemistry. So we have made a reflex code, like Dr. Ullas and me. I think it's been now 2 months. We have made a reflex code. Earlier, we had a reflex code for PDL1 along with the histopathology requisition, and now we have incorporated MTAP also on immunohistochemistry. So it
So
is,
MTAP,
and
yes.
yeah. So MTAP, the immunohistochemistry results are very good, and they are very much concordant with the CDKN2A homozygous deletion. The literature has supported that, and that MTAP IC has a fantastic results, and the literature also says that those patients who have these MTAP loss, they are not the one who are going to respond to immunotherapy. There is a persuasive evidence that they are not going to respond to immune checkpoint inhibitor in spite of having a high PDL1, and in fact they show better response to pemetrexed based chemotherapy, and definitely some drugs are there in trial. I think PRMT inhibitors they have
PRMT5
shown some they have shown some promising effect. Yeah.
Yes, yes. So, Umshi ma'am, can we incorporate this MTAP IHC in our practice?
MTAP IHC is there, but then it is not being done routinely for most of the cases. So unless and until very odd cases, but definitely we can incorporate that. And the panel that we will be having, the CGP, has MTAP gene in it.
Okay, okay. So it seems that apart from incorporation of MTAP gene in the panels,
IHC is a better bet.
it's
Yes,
a
like
good
it's
option
cheaper and it's
because
yeah.
correct.
In fact, in some other tumors also MTAP is helping us, like in CNS tumor, like if you have a grade 2 or 3 glioma that is showing MTAP loss, so that straight away becomes grade 4. Similarly, for
Absolutely.
meningioma, if you have an MTAP loss, it becomes a high grade 3 straight away.
Okay, so that's
And even for the mesothelioma, if you have a tiny biopsy, but you are not sure whether it's a mesothelial hyperplasia versus mesothelioma. So
Okay.
If it demonstrates an MTAP loss, so definitely it's 100% you are dealing with a mesothelioma malignancy.
Okay. So all these are very important points for the clinicians as well and all the oncologists, because I'm sure we keep on saying so many mesothelial hyperplasia versus mesothelioma. This is an important diagnostic dilemma, and most of the time we struggle to get the answer. And I think, as Dr. Sunil sir highlighted, this is an important IHC, a simple IHC, which can easily help us, and it is very specific as well. So I
It
think
is specific, yeah.
yeah, it is unlike ROS1 IHC, which is not so specific and require confirmation by FISH. I think it is much more specific and it will help us in treatment selection. It's a very good thing which we are understanding gradually. So coming to one of the cases, here will come the role of clinicians more in this case after getting comment from our molecular pathology team. So presently in all our tumor boards, I see the role of molecular pathologist has increased so much that 50% time we keep on discussing the report, molecular report, instead of discussing any other thing. So I think this is a shift which we are seeing in our panels. 50% time we try to dedicate the time for molecular based discussion. So that is a very welcome change, and it is good for understanding the tumor. And now with more incorporation of microbiome testing, I think understanding the host will also become more important. So this is a change. I think Umshi ma'am and Dr. Sunil sir both will agree with this comment. Yeah. Last time when we conducted lung cancer masterclass, we made sure that there are two moderators, one from the clinician side, one from the molecular pathology side, so that because we know it is very, very important to understand the tumor and the host to get to the best treatment outcomes. Yes. So let's come to one of the cases. 57-year gentleman, chronic smoking history, 30 years, back pain for 2 months, mild chest pain. You can see the scan, I think, yes. The scan, you can see there is some lesion which is in the mediastinum, and it was biopsied. CK7 positive, likely of TTF1 positive, NAPSIN1 also was positive, and negative for CK20. PDL1 score was done reflexly, I think, TPS of 5. And here we see KRAS mutation, P53 mutation. But just hold on. Most of the time as oncologist, what we see report, we focus on just the mutation, which is there in the box. What we must, as oncologist, we should look at. So we'll request again first a comment from Umshi ma'am, then we'll go to Dr. Krupa Shankar for his comment. Umshi ma'am, what things apart from the box oncologist should see before starting looking at the mutation, because it is a reflex that we look at the box, it is actionable or not, something like that. But what are the other very important key points so that we understand the nitty and gritty of NGS?
So yeah, first thing that you would see an NGS report is see like what panel has been used, what information that you're going to get, whether it is a hotspot panel or it's like a complete gene spanning panel. So here it is clearly written that this specific assay is looking for DNA variants and RNA fusions as well as, and also it is looking at like what is the total number of genes that you're looking at, and what was the platform on which this assay was done, and how the data analysis was done. So apart from that, then you'll be looking at like, what is the gene information, mutation, like at the gene level, and what is the transcript ID. This is very important. Like if you want to look into it, any other annotating databases, you need to trace the specific mutation correctly, and what's the amino acid change, and then the variant allele frequency. Then the variant tiers, like, whether it is tier 1, tier 2, that is as per the AMP and CAP recommendations. Also in this report, it's mentioned about the RNA filter. So like see the number of total passing reads, and you need to know what is the total depth of coverage. That's more important. Usually that will be there present at the end of the report, which will be telling about the quality perspective. So once all those things are passed, then you can say that, yes, you can trust this report, or just don't go by the box which is given to it. So you need to know what else is being done, and then from where you are getting these information. So like also here, apart from these mutations, you can see that there is a fusion information given. So the gene transcript ID is given, and what is the read count. So all that information one need to look at.
Yeah, ma'am. So Definitely, a lot beyond the boxes are need to be looked at. This is an important message to those who are attending. Just don't focus on the box. Apart from box, read the complete report in toto, because understand if it is from your own lab, you will know, because you are seeing those same reports from a longer time, and you know, and you must have interaction with the molecular team so that you understand the reports. One comment from Dr. Krupa Shankar. So when you see such report, Dr. Krupa, so what comes to your mind?
Yeah.
And
So
yeah,
yeah. Hi, Akhil. So first of all, nice to catch up virtually at least.
Yeah.
So yeah. So whenever I think the most important thing for me is to look at where the tumor content, the tumor DNA fraction as well, whether it's done on tumor tissue or whether it's a liquid biopsy also matters. And then again, look at the panel, look at the platform on which it's being done, look at the depth of coverage, the number of genes that are covered, and also the depth at which it's been looked at. All of these really do matter. And then again, what type of mutation has been picked up? And also, is it a classical, I mean, like the tier 1 or tier 2, like, is it a pathogenic, likely pathogenic, or a VUS, variant of unknown significance? Sometimes, I think a lot of clinicians, we only look at the box, like you rightly said. We don't look at the other co-mutations that could have been picked up, or the non-actionable mutations, as we would call it, or the identifiable mutations, which might have prognostic implications, if not therapeutic implications. So I think that's why it really matters. Look at all of these things. Look at whether it's only a DNA sequencing or a DNA plus RNA sequencing as well, because an RNA sequencing will help you pick up far more fusions and rearrangements as well. So, look at all of this. And again, look at the limit of detection of the assay, the LOD as we would call it. Because a lot of times we look at things that have been picked up, but that might be below the limit of detection of a particular assay that's been used as far as an NGS is concerned or a CGP is concerned. So those things you will definitely then look at having to reconfirm it, or we'll have to discuss with the molecular pathologist as to the clinical significance of something that's been detected below the limit of detection of a particular assay. So I think, having said that, I think, you will have to look at all of these things before we interpret an NGS report, and not just go by only what's written in the box, or look at only those that are actionable.
Yeah. Thank you, Dr. Krupa, for highlighting the very relevant and important points. Dr. Jain, I will request your comments now. So, as it was being discussed about the RNA-based NGS, so as clinicians, what is at your back of mind when you are ordering a test, whether it should be DNA? Because a lot of standard tests, still Foundation One, is based mainly on DNA. So, what is your important understanding about RNA-based NGS? Do you think it is important to consider RNA-based NGS, or even some good labs still do only DNA-based NGS? So what is your comment on that? Dr. Abhishek Jain. Dr. Jain is not there. Lalit sir, I think we can request you for the comments.
I think yet we are like in a more of a learning phase, and we are searching for people like you and Dr. M. Shri to teach us off and on about these issues. So
Yeah.
it's more of a learning, in fact, rather than interpretation, honestly.
Thank you. Okay, sir. Yeah, Shri ma'am, so we'll request you to highlight these points, because sometimes we get the report, tumor content is good, around 80%. Still, DNA report is there. RNA is uninterpretable. So what goes wrong that RNA becomes uninterpretable despite having a good tumor content? So what are the problems sometimes the lab
So
faces?
multiple factors gets into it, right from the kind of tumor fixation, the kind of paraffin, like there are multiple things goes into it. And what was the time duration? I mean, what kind of whether neutral buffered formalin was used, what was the pH, how it was fixed. So all those pre-processing parts play a huge role. DNA is relatively more stable as compared to RNA. So it is always easier, in spite of like having a good tumor content, we might get a good DNA and amplifiable region. So, and also mostly these are like around 150 base pair long. So it is easier to amplify that. But when it comes to RNA, to get a good RNA from FFPE tissues, it is always difficult, because many times what happens is that you might have really degraded RNA, or RNA integrity number is really low. So you might not get any amplifiable transcript from that. So that is the reason that you might end up getting good DNA, but not sufficient RNA. Sometimes in the laboratory, even when we have that low RNA, we still take it up and then go ahead with the library preparation, eventually to realize that it has not worked or it has failed. So that's the reason why you would end up. So it's a lot of pre-processing factors play a role. And also like the inherent tissue characteristics, the amount of necrosis and all those factors will also contribute to the degradation of the RNA. Otherwise, most of the time, DNA and RNA is, if it is well fixed, like, from a standard laboratory, if it is coming from the FFPE blocks, you can get it. But these are some of the reasons that RNA is not able to, analyze. And I usually prefer, my personal preference, like I know most of the laboratories have DNA-based panels for detecting fusions. But I do feel that sometimes you may miss some of the fusions. So it is always better to have a RNA-based panel so that you can look for all of the fusions. I mean, that's my take on it. I mean, others might differ on it. So this is from my experience, what I'm speaking.
Okay, got it. Completely agree with you, ma'am. Sunil sir, I would request your comments on RIN, RNA integrity number, and what is the interpretation? What a clinician should like? How should clinician should look at the RIN? Is it yeah?
Can you please repeat what the clinician should?
Look at and how to clinician can interpret the RIN.
So I think RIN means like
RNA integrity
The
number.
RNA integrity number,
Okay.
sir.
Yeah. So basically, it depends on these the factors that Dr. Omshri has already alluded that. It depends upon the very ideal fixation, the pH of the formalin. So all these factors actually that plays a role in for the integrity of this RNA based sequence.
Okay. Omshri ma'am, can you give some examples of RIN which are good, which are bad? How to interpret that? I'm not getting it
So
is difficult.
usually we do not mention it in these reports, but if you're speaking in the laboratory and FFP tissue, we always end up with always like a poor RIN. So anything like RIN value more than 1.8 or 2 is considered to be like a very good RNA integrity number from an FFP tissue. Of course, with fresh tissue, you do get a really good amount of RNA. And with FFP tissues, we always end up with like somewhere within 1 or even less than 1 RIN values, we end up getting it. But again, it's like a hit or miss. Sometimes even with the degraded RNA also, you would get the desired results. Like, there will be very good passing filter reads and you will be able to get amplifiable transcripts. But sometimes, you just cannot do anything with that.
Okay. Great.
And also it depends upon the age of the block, the storage and how it was processed. There are multiple factors.
Okay, got it, ma'am. Got it. So we got some idea about RIN. Thank you to Dr. Omshri ma'am and Dr. Sunil. Otherwise, it's we know that, but about the quantitative value, we didn't have any idea. So it's important to understand some of the basics. So if we see in this fusion report, there is a read count of 90. Now, as a clinician, what is the message to the clinician from the lab, whether it is significant, and if we look at the total passing filter read, what is the correlation, and how should we match this report with the filter read and read count? Again, requesting Omshri ma'am.
So from here, what it says is that the RNA reads have been like really good. The quality of the RNA library that has been prepared and the passing filter reads have been all above the threshold validity of good quality coverage. Among that, what we have got is this TPM3 NTRK1 fusion. So their respective gene transcript IDs have been given. So the fusion, the fusion reads, which is matching to that TPM3 NTRK1, the fusion region, is the reads are matching to those 90 reads are present. So there could be, read 1, read 2, some reads belonging to TPM3 and some reads belonging to NTRK1. And they might bind at some different places, but not exactly at the fusion region. So this 90 read count says that this is exactly binding at the fusion reads. And so you have a confidence that whatever fusion you have got, it's a correct fusion. So as per the recommendations, usually they say that, anything more than 5 read counts is good. But when that is the read count that you get in the laboratory, so we have a little bit of suspicion that, whether it is an overcall. So in that scenario, it is always good to go for an orthogonal testing if it is available. Otherwise, 90 is a good number to go with. And I would definitely say that this is a good data and this is definitely a true positive for NTRK1 fusion.
Thank you, ma'am. So again, a message to all the attendees. Any read count more than 5 is considered as important and positive. But if it is towards lower side between 5 to 15 or 5 to 10, there's no absolute number, but we need to be slightly cautious and look for the orthogonal testing possibility if feasible. Correct, ma'am?
Yes, correct.
Yes. So this is important message. So let's move further ahead. So final diagnosis, stage 3, driver mutation. It was, we see there is an NTRK fusion, not surgically resectable. MRI brain is normal, no financial constraints. So now how to move ahead with the treatment? Dr. Krupa, requesting your comments. This is a stage 3 patient. Now I think the usual plan would be CTRT followed by adjuvant immunotherapy. What is your suggestion, Dr. Krupa, in this patient?
Yeah, so I think, just a word before on the NTRK fusion as well. I think, if you look at the ESMO CAT recommendations as well, the idea is to look for the protein expression as well. So, you could definitely do an, IHC for NTRK as well to look at whether the protein is being expressed. Because, at the end of the day, remember, we're going to be using pretty expensive drugs like entrectinib, which is around 5 lakhs per month. So I think it makes sense for us to absolutely go ahead and verify this and make sure that the protein is actually being expressed on IHC before we offer treatment for NTRK inhibitors. Because even if you go back and look at the read counts, it doesn't say how much for each of the RNA fusion. So I think that's where the dichotomy is. And again, different labs have different cutoffs, and the standardization is different, especially depending on where you've sent the CGP or the NGS for. So I think, having said all of that, I would definitely look at doing an orthogonal testing or look at doing an NTRK on IHC as well to look for the protein expression before I even offer them any of the NTRK inhibitors.
Okay.
But getting back to your question of stage 3 unresectable, then I would definitely, here I would definitely go with CTRT. If it's definitely deemed unresectable, then I think there's no question about that. But again, the other alternative would be if it is probably borderline resectable, or they say probably you could, then I would probably lead in with neoadjuvant chemo plus IO here and then reassess. 3 to 4 cycles of neoadjuvant chemo plus IO, and then take a call, reassess, and then decide on RT at that point in time. Okay. That would be my go-to strategy.
Yeah, I think it is important to understand very important points, including treatment for adjuvant setting, treatment for neoadjuvant setting. This is a patient where definitive CTRT was being planned, and the case was being discussed in a tumor board comprising radiation medical surgical teams, and as well as pathologist and nuclear medicine and radiology team. So this patient was planned for definitive CTRT. Now, if we see such reports, Dr. Mushi ma'am, again, a comment from you is needed. Do you think in such NTRK fusion positive patients, adjuvant immunotherapy will be an optimal strategy? Approvals are separate. Approvals are completely separate. But do you think for NTRK, because we don't have very good data, NTRK is not so common, so we'll have limited data. So any comment on that, ma'am?
I think if financial constraints are not there, so I think that can be considered, though there is the data is emerging.
Yeah. So I think there is no clear answer to it. That is
Absolutely. Yes.
For adjuvant RET fusions, there's a study ongoing. Adjuvant salpercatinib study post-surgery. That study is recruiting. So gradually we will have some studies, but NTRK still is very uncommon fusion to get. I think Dr. Abhishek, I will request your comment as well. So in such situation, and NGS has already been done. Most of the time, if only EGFR, ALK, and PD-L1 is done, it becomes easy to select. But if NGS has been done, and you get an uncommon mutation on fusion, how do you integrate that into your practice? Dr. Abhishek, requesting your comment.
Yeah, Dr. Akhil.
Yeah.
Hi. Yeah.
Hi.
Yeah, I think since I'm a surgical oncologist, I would definitely depend on my medical oncologist to take that call. And most of the time, it is they who take a call on this. So, right.
So I will request your comment on the part. You can give
I mean,
very briefly.
I don't even remember when.
Completely understand. It is uncommon. It might happen. You can get it one.
Yeah, Dr. Akhil, just one question.
Yeah.
So you're saying this is stage 3, not surgically resectable. Why surgery was not an option? Can I?
So yeah, I think it was discussed in tumor board and it was found that descending thoracic aorta 270-degree encasement was.
What was the size of the
So
tumor? There, as far as I remember, there was no mediastinal node, right?
yes, there was no mediastinal node. So what
Right.
I require your input as a surgical oncologist.
Yeah.
What 3 or 4 points you look before calling the patient unresectable, so that
Yeah, I mean,
we can.
I mean, if it's stage 3 till 3A, I would definitely consider surgery as a part of management of any lung cancer patient.
Sure.
So, and especially if it is a single station mediastinal node, then why not neoadjuvant chemo immuno followed by surgery? So, so basically up to stage 3A, single station. If it's bulky N2 disease, then definitely CTRT followed by Durva. But otherwise,
Okay.
definitely, I would very strongly consider neoadjuvant chemo immuno followed by surgery. Yeah.
Completely
Because we
agree.
have
So
seen
I-
excellent responses with immunotherapy now, and
Correct.
it's been a game changer. Yeah.
So definitely, I think the comments by Dr. Abhishek are very valid, and this is our strategy in our tumor boards as well. Any patient to stage 3A is considered for treatment with neoadjuvant chemoimmunotherapy followed by surgery and followed by maintenance immunotherapy. So that is the usual paradigm at present.
Right.
But if patient is deemed unresectable, I think we go towards the CTRT pathway followed by
Yeah,
adjuvant durvalumab.
definitely. Yeah.
So again, there was a Pacific 2 trial which tried to look at whether you can incorporate immunotherapy during radiation, whether it adds anything to survival or not. That is a negative trial. Now, Pacific 8 trial is also enrolling at our center, just to make sure that we can keep on discussing about trials, which is looking at improving outcomes from 5 to 15 months. That is was there in Pacific trial. You are just CTRT outcomes of median PFS is towards 5 months, and it is improved median to 15 months. Now, durvalumab plus domnavalimab, which is another drug, another TIGIT inhibitor, is trying to look at whether anything addition to durvalumab is leading to improvement in further outcomes or not. So I think we keep on evolving from time to time. A paradigm has been established. Concurrent immunotherapy with RT in lung cancer doesn't help. Pacific 2 is negative. So Pacific 8 is trying to intensify adjuvant immunotherapy. Also, there's a trial which is looking at multiple other mechanisms to look at the responses. Yes, Lalit sir, you wanted to highlight something.
No, in fact, wanted to tell about the IO plus RT is like more of toxicity and less benefit, which you have already told. So just wanted to tell that. And this Pacific 8, like at our center also, we have ongoing Pacific 8 recruitment, and one patient we have completed total 1 year, and like patient is still well for almost 2.5 years total duration if you see.
Yeah, completely agree with you, sir. So when we get some these type of fusions in curative setting, it becomes a slightly a difficult problem, and we might not have answer to each of that. So we become confused, and taking decision is left to most of the time discussion with the patients. And yes, we know these anti-RK inhibitors are useful. Response rates are high, 60 to 70%. So in fact, we have good data in metastatic setting, but not in curative setting. So that remains a problem. That is why we need to make one-on-one decision discussions with the patients and the family and take decision accordingly, because there is no good data for the same. So we must understand the limitations of science at present. Though we might have a fusion, we don't know whether in adjuvant setting adding these drug will prolong survival or not. So it is though tempting to act, but we most of the time we have to hold our horses and just give most of the time a standard of care treatment. In rare scenarios when the patient wishes, we offer them the option of out of box treatment, out of protocol treatment with written consent. So that is our usual protocol at present. Hopefully the data will evolve. Like we saw that there is already results for adjuvant EGFR, adjuvant ALK, and now adjuvant RED trial also in ongoing. KRAS G12C inhibitors trial are also started, not only in metastatic setting. Presently, SunRay 2 is also enrolling, which is adjuvant KRAS G12C inhibitor in addition to immunotherapy. So Olomarcib plus pembrolizumab as an adjuvant, Olomorphic plus durvalumab as an adjuvant treatment trial is also recruiting at our center. So beyond EGFR ALK, this is the importance we are learning, and multiple trials are enrolling presently, and it is difficult to keep abreast of all these knowledge. That is why it is important to keep on discussing in molecular tumor boards and tumor boards, so that we can keep on sharing the experience and knowledge. So
I would like to add one more point here, Akhil. So here, apart from these fusions, it's also important to know whether it is a cold tumor or a hot tumor. Even the TMB also plays a role here.
Okay, ma'am.
Yeah, that's one more thing to just keep in mind, apart from the various things that we are discussing.
Okay, ma'am. So it's an important point that we can understand the tumor is hot or cold. TMB is an important marker, though it will require a larger panel, and I think CGP will help. Our CGP will cover that, ma'am.
Yes, it does. It does.
So CGP helps us, and thankfully the CGP cost at our center is 40,000. Hopefully it will come down further, and the TMB will be included in a lot more patients. Previously, the TMB was costing as part of CGP more than 1 lakh, but now it is costing below 50,000. That is a good news for all of our patients. Yes, sir.
Yeah, and Dr. Omshri, question to you, like we have TMB, PD-L1, MSI and TILS. So how do we interpret it? Like one thing is available in some tests and something is available in other tests. So any quick note on that?
So all are what do you say, add-on markers or the surrogate markers for each other. So PD-L1 has been extensively used in scenarios when CGP, like for tumor mutation burden, you need to have a larger gene panel, like Akhil rightly mentioned. So like the smaller gene panel will not be able to help you calculate the tumor mutation burden. And again, it has an additional cost to it, whereas PD-L1 IHC is something reasonable, which you will be able to get fairly an idea, like, whether you can go ahead with the tumor positive, the TPS score is good enough. But with TMB, if it is like more than 400 to 500 gene panel, then it becomes easier for you to calculate the tumor mutation burden. So again, in that, there is a certain cutoff that needs to be set up. So anything that is more than 10 TMB is considered as high or low. And then MSI again is another marker altogether. So most of the time, it is included in even a smaller targeted panel. So you would have at least 6 to 12 different loci of MSI, which can be detected along with it. Or you can have a battery of IHC, which can be done. Or you can do it separately based on a ddPCR or a PCR-based assay. So all of it collectively would definitely help you to come to a guided decision. Depends upon what is available in the institute or what is more cost-effective, sir.
Thank you. Thank you so much.
Thank you.
Hi, Akhil, Kripa here. So I just
Yes.
wanted to make a point, especially when you talk about TMB, because a lot of times we get confused. The cutoffs for TMB on tissue and on liquid biopsy are different. So this TMB of more than 10 mutations per megabase is on the tissue. So if you're doing it on liquid biopsy, then, for example, if you're doing it on Guardant, the cutoff is 30. And if you're doing it on FoundationOne, it's more than 28 mutations per megabase. Always remember that on liquid biopsy, the cutoff for TMB high is much higher as opposed to doing it on tissue. And then again, the other issue with having a driver mutation positive as well as having a high, PD-L1 MSI or TMB as well. See, for example, if you have EGFR exon 21 L8, we know the incidence of co-mutations there are also higher. Like you could have a P53 or an RB co-mutation there. So you can have a high TMB in those sort of settings as well. But we always rely on targeting the identifiable driver mutation or the actionable genomic alteration, as we would call it. So, just because you have a, high PD-L1 or high MSI or a TMB, even in an EGFR mutant patient, we wouldn't look at using IO there. So, apart from hot and cold tumors, I think, now we're getting warm tumors as well, which are neither here nor there. So, we talk about KRAS, BRAF, and MET. We know KRAS is hot. IO does work. But especially if you have other co-mutations like STK11 or KEAP1, then, IO doesn't work much, as well as, without having those other co-mutations. So I think that's where, how doing a CGP really comes into its own, because you're able to pick up these co-mutations. You're also likely to identify who's likely to benefit much more. The magnitude of benefit does differ. So if I were to put it in a nutshell, I would say probably KRAS, BRAF, and MET are slightly hot tumors. And then again, EGFR, ALK, and RET, they're all cold tumors. So, I think that's how I would look at putting it. And again, this is again from the ESMO-CAT consensus recommendations as well. So I think in practice, I think that's what we should look at doing as well. Okay.
So very nicely summarized by Dr. Krupa about hot, cold, and also some warm tumors. STK11, KEAP1. I think this is a very fast evolving area. Some data, though not very strong data, a CheckMate 9LA regimen which incorporated double IO that showed that STK11 KEAP1 mutation effect can be overcome, but that is a subgroup analysis only, which we must understand. But if you get STK11 and KEAP1 and there's no targetable mutation, you are starting immunotherapy, there is some subgroup data that double IO might be somewhat better. So, but this is a subgroup analysis, a hypothesis generating, not necessary practice changing, but we can keep that in the mind before deciding the treatment options. So I think in the interest of time, we'll take 2 or 3 questions which are there in the Q&A sessions. There's a question, selected questions which we'll take. Is adjuvant Durva given irrespective of PD-L1 status? Dr. Krupa, can you highlight the answer rapidly?
Yeah, definitely. I think, but there is a dichotomy here. I think, like they say, the US and the Europe, they don't agree with each other. FDA approval is different from the EMA approval.
Correct.
So the US FDA says it's approved for all comers. EMA, at least more than 1%. But I think, like I said earlier, the magnitude of benefit definitely is higher in patients who have a high PD-L1 expression. Albeit there are definite issues as to when you would like to do the PD-L1. Should it be done right up front, or is it after CTRT, where we know the PD-L1 expression can get upregulated, post CTRT as well. So, that's an open question. But, if you look at the blanket FDA approval status, it says for all comers. But the EMA says it's more than 1%. But I think in practice, if you have a non-oncogene addicted, probably in the EGFR, now we know we have the LAURA data. So, we're going to do EGFR inhibitors there. So if it's a non-EGFR mutant, then I think, we justified in offering them, albeit, with the caveat that the magnitude of benefit is likely to be lesser in patients who don't have high PD-L1 expression. So that's how I would put it, Akhil.
Greatly agree. Approvals are there. You can choose which one you would like to follow. The magnitude is different in terms of the benefit. One more last question which we'll take. Importance of checking MRD status or ctDNA on treatment for the patient. So that is a very evolving field. We do not have very good data in lung cancer at present. So data is evolving in colorectal space. But Dr. Sunil sir, would you like to give some comments on that point? Please unmute yourself, sir.
So you have rightly said that we don't have a very robust data for this, but yes, it is emerging as a very good predictor of a biomarker for the response to therapy. And the ctDNA, if it shows, if the value gets minimized or if it gets undetected, so it shows a promising effect and shows a good risk prognosis for the patient.
So we need more answers, more
Yes.
research in this aspect to understand these things much better.
But it has shown a promising.
Yeah, definitely a lot of promising data. So I think in the interest of time, we would have to stop, else we can continue discussing it for hours together. Even molecular tumor workshop of 6 hours is not enough. 3 days of lung cancer masterclass is not enough for these discussions. So I think we need to stop somewhere. Back to Suman sir and Savita.
Thank you, Dr. Akhil. I think it was a very enlightening panel discussion. All the pathologists and the medical oncology and surgical colleagues, thank you for a discussion. I think we now have Dr. Kumar Prabhat sir with us to give us a brief outline and conclude this session. Sir needs no introduction, and when it is lung cancer, I think no one better than sir to guide us through the end of this webinar. Sir, over to you, sir.
So, good evening, everyone. And at the outset, I'd like to thank ISU and especially Dr. Savita for inviting me for this session. Akhil, that was a wonderful session, as usual. All the sessions we learn when he presents and when he does this moderation so well. So what we learned that, am I audible, Akhil?
Yes, sir. You are audible.
Yes, sir.
So I think so in today's time, as someone commented, that we can't get away with molecular testing and targeted therapy in any situation in lung cancer. maybe except for screening and maybe except for some of those GGOs where we may end up operating. So it is important to learn, and for all of us, not only for medical oncologists, for our surgical oncologist colleague and for our radiation oncologist colleague, because their input regarding not only knowing what is the report, the tissue, how important it is. And we heard that it starts right from the beginning when getting the tissue. And today also, almost 20% of the patient, we are not able to get adequate tissue for doing the molecular testing. And we end up relying on liquid biopsy, end up doing repeat biopsy. So all of us, it is important to know those molecular testing. And it is good that we have ISO as a forum where we do have multi-speciality discussion, which is there, so everyone gets sensitized. Thank you so much. I did learn, and I'll request other modalities, be sensitive about this molecular testing when you hear from your medical oncologist colleague, pathologist, molecular biologist, that we need to have adequate tissue, need to have adequate and appropriate fixation. And that is where then finally it goes to the molecular lab from where we get the report. So thank you so much, everyone, for wonderful discussion.
Thank you, sir.
Thank you, sir, for that concluding remarks. I think ISO is in that way a very good platform because this is a body where we have all subspecialties of oncology. Can I request our president, Dr. Hemant Malhotra, sir, to guide us through the ending of this webinar? Sir, are you there?
Yeah, I'm very much there, Suman. So, I think both Guru and the Chela, I mean Kumar and Akhil, they've done a wonderful job. And particularly Akhil, he was very meticulous in his panel discussion, as the moderating the panel discussion. And Akhil is truly a gem in our medical oncology faculty. And the way he is conducting his department and the way he's risen in the medical oncology world is really admirable. My senior residents, the DM students at my centers are absolute fan of Akhil. And of course, inputs by the other panelists, all of them, Sunil, Abhishek, Dr. Omshri, Lalit, have been wonderful. And I think we've touched an attendance of 150, which is again good for a webinar of this kind. And my most sincere thanks to Akhil and all the panelists for their inputs and their time. And of course, the ISO core team, Dr. Savita, Dr. Sumant, for stitching all this together. So I hope, and of course, many thanks to all of those who are attending this webinar. And I'm sure that you must have benefited at least a little from the discussions. If you have any inputs, if you have any suggestions for us, we are very open to listen to those and accept those. And whatever criticisms you have, positive or negative, we'll be happy to hear that and improve that and incorporate that in our next webinar. So thank you very much. Sumant, back to you.
Thank you, sir. So once again, I thank you everyone for this beautiful webinars. And I think we'll have the next one coming next month. Thank you everyone for joining in. And thank you, Dr. Akhil and the panelists for this beautiful session. And of course, Dr. Kumar, sir. Thank you everyone. Have a good night. See you.
Thank you. Good night.
Thank you. Good night.
Thank you. Bye.
Thanks.
Sir.